Next, we have Dr. Rahul Sharma presenting on pulmonary follow-up of bronchopulmonary dysplasia patients, a case series.
Good morning, everyone. Today I'm going to present a study which is still ongoing at our center, that is pulmonology follow-up of bronchopulmonary dysplasia patients. So BPD, or as we call it as chronic lung disease of maturity, is a very common condition seen in preterms and ICU graduates. And the two most important risk factors for BPD are prematurity and low birth weight. And as we all know that these children are at a risk of developing neurocognitive and other complications, but most important of them are some pulmonary comorbidities like recurrent wheezing, tracheobronchial, subglottic stenosis, gastroesophageal reflux, pulmonary hypertension, and other sleep-related issues. Hence, it is very important that they need a close follow-up with the pediatric pulmonology unit. Hence, we did this study with the aim of studying the spectrum of various pulmonary comorbidities seen in these BPD patients. We also wanted to correlate the severity of BPD with various comorbidities, and we would also like to study the impact of BPD on lung function of these children at school age, which will be done later. So this is still an ongoing study, prospective cohort study at our center, and all the patients enrolled in the pediatric pulmonology unit at our hospital are included in the study. Till now, we have only the data of 6 patients which have been enrolled till now in our study. We included all those newborns which were managed in our NICU and were diagnosed as BPD as per the NIH criteria, while we excluded those newborns who were managed in an outside NICU, and we also excluded those who were not willing for regular follow-up at our unit. So this is a table showing the new BPD criteria as per NIH, which we use for the diagnosis of BPD at our center. There are some other criteria which this NIH criteria takes into account the gestational age and the FiO2 requirement to grade the severity of BPD. There are some other criteria also which are used by Jensen and revised NICHD, which also take into account the oxygen device modality, but the most popular nowadays is NIH criteria. So we included all those babies, and we took the NICU details and noted in a set performa, and details like gestation age and birth weight were recorded. Then these children were advised to follow up in the pulmonology OPD every 2 to 3 months or earlier as if the need occurred. The details of the follow-up visits were recorded in the same performa, and investigations were done as per the need. And we also plan to do the pulmonary function test of these children on follow-up at school age. So what did we observe? This is a table showing the NICU details of all these 6 cases, and as you can see, they have a birth weight ranging from 890 grams to almost 1.4 kg with a mean of 1.180 kg and a mean gestational age of 30 weeks with a mean NICU stay of 73 days. All these children required mechanical ventilation for almost 2 weeks with prolonged NIV, non-invasive ventilation support, and oxygen therapy. We saw that 2 of them had moderate BPD, but 4 of them had mild BPD. We followed up these children for a period of ranging from 4 months to 11 months, and we saw various pulmonary comorbidities on follow-up. As is evident from this graph that almost all had bronchiolitis, and all these episodes were severe, requiring ICU admission and non-invasive ventilation. 2 of them developed pneumonia on follow-up, out of which 1 had severe pneumonia requiring ICU admission and mechanical ventilation. Persistent wheezing was seen in 2 of these children, while gastroesophageal reflux was seen in 1. Persistent tachypnea was noted in 4 of these children on follow-up, and 1 of them had to be started on home oxygen therapy due to sleep-related hypoxemia noted on an overnight pulse oximetry study. So when we reviewed the literature, there are a lot of studies which have been done on BPD, and all of them show that these children are at a risk of developing various pulmonary comorbidities on follow-up. I have summarized a few of them here. So as you can all see from this table, that all these children are at the risk of developing bronchiolitis and respiratory illnesses requiring hospital admissions. They are also at increased risk of developing asthma and recurrent wheezing on follow-up. In an interesting study done in 2010, they also showed that almost 25% of these children had pulmonary hypertension on follow-up at 2 months, while a study in 1998 in which they did flexible bronchoscopy on 47 children with BPD showed that 45% had tracheomalacia and 34% had bronchomalacia. In a study done on 14 BPD children in 1988, it showed that they had higher hypoventilation and hypoxemic episodes during sleep with a mean arterial oxygen saturation of less than 90%. And thus it is summarized that they also have sleep-related issues. So as we have seen that BPD children are prone to develop multiple pulmonary comorbidities on follow-up, and hence we plan to continue this study for a long period of time to get a good size cohort. And we also plan to do lung function of these children at school age. These are my references. Thank you.
It's quite a neat way of doing it. I know you've only got only 6 to present now, but I like the way that you have got the pro forma and everything like that. Do you send babies home on oxygen?
Yes, sir, we do. Sometimes if a child requires prolonged oxygen therapy in an ICU and we are not able to wean off the oxygen, then sometimes in very rare
And
cases.
do you do routine follow-up checking for pulmonary hypertension?
Yes, sir. We advise them to do routine follow-up for pulmonary rehabilitation. But as it happens everywhere, that some of these patients are lost to follow-up, while some of them are far, so they cannot travel to us for follow-up. So, but those patients who come to us, we advise them to come routinely.
Okay, thank you.
Could I just ask you, do the babies all routinely get RSV prophylaxis?
Sorry.
Do they get RSV prophylaxis with palivizumab? RSV vaccine?
RSV vaccine is not very rampantly available in India, so it's not very feasible to give these children.
Sure, because you just need, all of them got bronchiolitis as far as I could see. I was just wondering if you used it.
Yeah.
Okay, maybe that would have helped.
May I? Excellent presentation.
Yes, sir.
Thank you.
Thank you, sir.
So one comment only, and that is while presenting this data, one more thing is on failure to thrive. How many of these children did not thrive very well, because that is also will affect the outcomes.
Yeah.
So when you compare those who developed BPD versus those who did not develop BPD, and those who are within the moderate and mild category, how many of them had difficulty with gaining weight?
Sir, all those, in the graph that I showed in which the pulmonary comorbidities were listed, so the 4 children which had persistent tachypnea on follow-up, they were failing to thrive. But later on, on later follow-up, they started to gain weight also.
Okay. Because that is one confounder in this BPD. Okay.
Yeah. Thank you, sir.